All right. So I was invited by Dr. Scott to talk a little bit about acute shoulder pain, and so I'm going to focus on. I'll walk through some case studies, and we'll talk a little bit about shoulder pain and how someone would manage acute shoulder pain in the outpatient setting. Next slide. These are my objectives. Essentially, what I'm hoping to do is help you understand a few of the common things that will often appear with acute shoulder injuries and develop evidence-based treatment plans so that your patients can get better. Next slide. I brought this in because I think there are several challenges that as primary care providers we experience. First off, I don't know what your medical training was like, but certainly my medical training did not strongly emphasize the musculoskeletal examination. And it was something that I had to emphasize and seek out independently to improve in my medical training. The other thing that you will find is in the orthopedic literature, you can often find different examination techniques. So different orthopedists will examine shoulders in certain ways and they will use different terminology. And that can sometimes really complicate a primary care physician's understanding of the best way to examine a shoulder. We also recognize that that the examination techniques, there are some limited evidence in terms of how valid these techniques are. So that can add also to our challenges when we're working with the shoulder. The other thing I would add is many times acute shoulder injuries are not always going to present to the primary care provider. They may go to an urgent care or an emergency room. And so consequently, many primary care providers feel like they don't see a larger volume of these types of injuries and consequently may not feel as comfortable handling these injuries. In my area, sometimes I deal with patient expectations that any kind of shoulder or joint injury needs to be seen by an orthopedist. I practice both primary care and sports medicine, and it's very interesting. I have some patients who come in, and despite the fact that I see a large amount of acute musculoskeletal injuries, they still want me to refer them to an orthopedist prior to a substantial workup. And I would guess that many of you have had the same experience. We talked a little bit about my last point, and that is for many of these reasons, primary care providers can have limited opportunities to diagnose and treat acute musculoskeletal injuries. Next slide, please.
Dr. Hall, so this is David. And yeah, I get to treat a little bit more out here in rural Nevada since our closest orthopedist is 100 miles away. So yeah, it's fun stuff anyway. And so that's there is a lot that primary care can do. And of course, the stuff where I'm like, ooh, I think that needs a surgery, or that's really broke. Of course, that's definitely going.
Sure. Thank you for that. I was going to walk through just some of the basic anatomy so everybody is oriented before we jump into some of the case studies and differential diagnoses. If you look at the bony anatomy of the shoulder, I mean, there are three key bones that I want to point your attention to. So you've got the clavicle, which is superior. Next up, you've got the scapula, which includes the acromial process. And then we've got the humerus, which articulates with the scapula, forming the glenohumeral joint. So I just wanted to show that so everyone would be familiar with the bony anatomy. Next slide. When we talk about the shoulder joints, there are really three synovial joints that are included in the shoulder joint complex. First, you have the sternoclavicular joint. Second, you have the acromioclavicular joint. And then third, we have the glenohumeral joint. Depending on how different people define a joint, you have the scapulothoracic articulation, or some people call it the scapulothoracic interval. It is not a synovial joint like the other three that I previously named. And so even though we include that as a potential articulation, just recognize it's not a synovial joint like we think of the others. Additionally, when we think of the shoulder joint, most people think of the glenohumeral joint. But we do include anatomically the other joints involving the clavicle as part of the shoulder. So I wanted to point that out. The other thing that if you look at the side view on the right-hand side of this slide, you can see, yes, a lateral, I'm sorry, a view of the shoulder from the lateral position. And what I want to call your attention to is the cartilaginous rim of the glenohumeral joint called the labrum. So we're going to talk a little bit about that structure as we move forward. Next slide. So when we categorize different shoulder injuries, obviously we can have bony injuries or fractures, muscular injuries, and that's primarily rotator cuff tears, but there can be other types of muscular injuries, ligament injuries, and I'll show you some of the ligament injuries that we can experience in the shoulder. Cartilage injuries, that primarily means an injury to the labrum. And then certainly whenever I am evaluating an acute shoulder injury, I often want to include in my differential diagnosis any cervical spine pathology that may be radiating or referring to the shoulder. And so those are some different general categories of how we're going to look at shoulder injuries. Next slide, please. When it comes to the physical exam, I'm not going to spend a lot of time on this, but I outlined a couple of steps that I think are important. Number one, I always try to expose the joint. Certainly that's easier with our male patients, but many of our female patients, in my office, we have little paper vests that we can change them into. And the reason for that is many of you have probably had an experience of looking at a shoulder. You want to be able to see the anatomy. You want to be able to see any bruising or swelling. And additionally, we want to be able to see the skin and see if there's any rashes or other things that could influence our differential diagnosis. When we inspect the shoulder, one would want to look both at the anterior and posterior aspects of the shoulder. The reason for that, and many people will often omit the posterior inspection, but the posterior aspect of the scapula is where the rotator cuff musculature originates. And so I feel that's important because when you're evaluating a shoulder, you want to look for an atrophy of those muscles because that can assist you in determining a rotator cuff tear and how chronic a rotator cuff tear is. Palpation is going to include palpation of all the structures that I mentioned previously. So I tend to start at the sternoclavicular joint and work my way laterally. Next, we want to do full range of motion. So the shoulder is the most mobile joint in our body. So there are actually 6 planes of motion with flexion, extension, abduction, adduction, and then internal and external rotation. So one wants to assess all those different motions as part of the examination. Next, we're going to talk a little bit about strength testing, and that's primarily focused for me on the rotator cuff musculature. So I described in written form a way on physical exam to isolate the supraspinatus muscle. Many people know this as the empty can test, but essentially it's bringing the shoulder into about 90 degrees of flexion, forward about 30 degrees, and then have the thumbs pointing down, and then we have the patient resist the examiner in pushing down on the arms. You note in my slide, a positive test could represent pain or weakness. And I wanted to define that a little bit because I think there's an important distinction there. And the distinction is this: if someone has reproduction of pain with this test or with other rotator cuff tests, that's more suggestive of rotator cuff tendonitis or irritation of the rotator cuff, which contrasts with weakness. If someone has weakness on those tests, that shifts our differential to more of a rotator cuff tear. So I wanted to emphasize that whenever we're doing any of the rotator cuff muscle testing, pain and or weakness can influence what we're thinking on our differential. And obviously the rotator cuff is composed of 4 muscles. I mentioned the supraspinatus test, and the other tests would include the infraspinatus and teres minor, which primarily act as an external rotator to the shoulder, and then the subscapularis, which is an internal rotation, or which acts to create internal rotation at the shoulder. There are some additional tests. I mentioned one that I'm just going to comment a little bit on. This is one of the areas where orthopedists who focus on specific joints, they may use some different terminology. and that can be very confusing for primary care physicians. I try to discourage the use of these orthopedic words like speech test and other things, but recognize that orthopedists will use that terminology, and you may not fully understand it, but I'll try and describe two common things that we will often use specifically with impingement testing on the next few slides, so that we're all familiar with some of the terminology there. On physical exam, one thing that's going to be important in the context of an acute shoulder injury is an assessment of an individual's ligamentous laxity, or how flexible they are. And so when we've got an acute shoulder injury and we're concerned about a shoulder dislocation, it can be very helpful to examine the contralateral side and see how much flexibility an individual has. There's a specific sign called the sulcus sign, and I've pictured that on the right. What you can see is the shoulder without any traction on the left, and then a shoulder with downward traction on the right. And what you'll notice is there's a subtle sulcus that forms over the lateral aspect of the shoulder just below the acromial process. That's an indication that you have inherent ligamentous laxity in the individual you're examining. The other test of stability is what's called the apprehension test, and that's where the shoulder is brought above, the hand is brought above the shoulder in external rotation, and there's a little gentle external rotation force applied to the shoulder to see if the individual becomes apprehensive with that. And that would indicate someone who has some shoulder instability, likely from a previous shoulder dislocation. So those are two tests I wanted to focus on with this slide. Next slide, please. The next two slides, I'm going to focus on two terms that I hope you can retain from my discussion. So there are two main tests that physicians will use to assess what we call impingement, which is dynamic narrowing of the subacromial space in the shoulder. The first one that I've got here is called Hawkins test. And if you look, you see the examiner has the patient's arm in a position, and then the arm is internally rotated, and you're looking for pain. So the positive test is reproduction of pain with dynamic motion as described in the picture. Now, it was originally described as a Hawkins-Kennedy impingement test, but it is now commonly just known as a Hawkins test. And the way I tell my students and residents to remember this test is that it looks like a hawk moving their wing. So if you remember that, you can remember how to do this test and the terminology that the orthopedist will often use. Next slide, please. This is the second impingement test that we commonly use. It's called Neer's test, and it's where the examiner takes the arm and moves the arm in an arc of forward flexion up toward the ear. And the test is positive if it reproduces pain. This test you can remember because you bring the arm near to the ear. So near to the ear. So we have two main tests for impingement syndrome. One is Hawkins test, one is Neer's test. And I hope that you can remember that terminology as we move forward. Next slide. I'm now going to jump into some case studies. These are all individuals that I've dealt with, and I will walk through these injuries, so I hope you can learn from these case studies. This is a 21-year-old quarterback. He went down pretty hard on his right arm, on the outside, I should say, on the outside of his right shoulder, and it was one of those tackles that when you saw it, you had a high index of suspicion for an injury. When he came off, he was holding his arm by his side, didn't really want to move it, and had pretty high levels of pain. He didn't report any previous shoulder injuries or dislocations. And the question that I've got for the group is, what would your differential diagnosis be here?
Easy.
Fracture.
Good. So I heard AC joint injury. I heard fracture. I think those are the two main things that I would also be concerned about in this particular instance. Next slide. So this mechanism of injury is classic for an acromioclavicular joint injury. So this is known by the layperson as a shoulder separation. And what happens is you get a compressive force from the lateral aspect of the shoulder. And if you think about where that force will transmit, it will go through the acromial process and then onto the acromioclavicular joint. And that tends to be the weakest area. So you often get either a fracture, or more commonly with this mechanism, you'll get an acromioclavicular joint sprain. So I've described a common mechanism of injury here, and I tend to see it most commonly in my athletic population. So I mentioned this was a football player. That is the usual individual who will get this type of injury, but you can see it in anyone who falls onto the outside of their shoulder. Clinically, these folks will be very tender over the acromioclavicular joint when you examine the shoulder, and the orthopedists grade these in a number of different grades, and I will show you how they grade these, and it relates to the type of ligamentous injury included in the acromioclavicular joint. But the key thing to remember here is most of these, the vast majority of these, are either grade 1 or 2. And I don't know that I've ever seen one, at least not in my recent memory, that has needed surgical treatment. So although you can get a higher grade acromioclavicular joint injury, they're less common, and most of these can be managed quite well by the primary care provider. Next slide.
Dr. Hall, this is David again. Yeah, so I had a motocross guy get this a month ago, same mechanism, crashed, shoulder right into the ground. So I did phone an orthopedic friend. And yeah, he said, yeah, the majority, like he said, the vast majority heal just fine. And then he said, I could do a surgery anytime, depending on how the healing process goes. Outcomes are pretty similar, whether it's new or old. So that extra 2 cents.
Yes, thank you. That's exactly right. So if you look at the picture on the right, you'll notice the different grades that the orthopedists use. And there are 2 things I want to call your attention to on this slide. So you have the joint capsule of the acromioclavicular joint, and then you have a restraining ligament, the coracoclavicular ligament that connects the coracoid process with the clavicle. And those are the usual structures that can be injured. And that's the first 3 grading scales are listed there. And since those are the most common, that's what I want you to focus on. Most of the ones that I see are going to be grade 1 or grade 2. And the key thing to remember is if you see any of the injuries that are grade 4, 5, or 6, so those do need to be sent to an orthopedist. And just so you know, those are going to be typically very high levels of trauma, and should be clinically obvious that we need to involve an orthopedist with them. Grade 3 injuries, there has been some ongoing debate about the appropriate management of a grade 3 injury. You can see I included one study that looked at this clinical question and compared operative with conservative management, and essentially there was not a great advantage to operative management of a grade 3 injury. So I just wanted to throw that in there so everyone could understand that there may be some grade 3 injuries that the orthopedist may want to operate on, and that one's more of a clinical judgment. So anyway, now you're familiar with an acromioclavicular joint injury. Let's move on to the next one. This was a 72-year-old male called my office because he had slipped and fell down the stairs. He had a lot of pain, limited motion, and he was at work when this happened. And the funny thing was, well, I'll tell that part of the story a little bit later. But anyway, his assistant brings him in to my office. We get him in the office, and he was in a lot of discomfort, didn't really want to move his arm. And when we got his shirt off, we could see that his humerus was located a little more inferiorly than we were expecting. Everyone in the examination room was suspecting a shoulder dislocations, and we talked about different treatment options, and essentially moved forward with a relocation, which we were able to accomplish there in the office, and then subsequently completed imaging to confirm that the shoulder was relocated. The funny part about this story is I had one of my residents with me, and literally 30 minutes before this happened, she asked me about treatment of shoulder dislocations. And I kind of told her, I said, gee, you know, I've really mostly done shoulder relocations, you know, when I've been on the football field. I'm like, they never come in my office. And then, of course, 30 minutes later, this guy showed up. Many of these, having said that, many of these are going to present to an urgent care and emergency room. So those of you who work in those types of settings may be more familiar with this than the typical individual who works in an outpatient setting. I'm a little unique just because I see so many acute injuries that folks will still come in with this type of injury. Next slide, please. When we talk about a shoulder dislocation, first understand it's the most common dislocated joint that we tend to see. Usually involves some kind of direct trauma. I mentioned sporting injuries or falls, and essentially you get excessive external rotation and abduction. Almost all of these are what are called anterior dislocations, so where the humerus dislocates in front of or anterior to the glenoid process. And obviously the presentation is as I described. You've got someone who doesn't really want to move, they're in a lot of discomfort, and that's how these typically present. Next slide. Couple of things to know about this. So number one, I described in my discussion a relocation in my office, and I felt comfortable doing that just because we had a patient who requested that, and I've obviously had some experience with this, but many of you may not have had the experience because, again, most of these are going to present to an emergency room. I would also say that trying to relocate a shoulder without any kind of anesthesia can be a challenge for many people. And so don't feel like if you have a shoulder dislocation, you should feel very comfortable getting that individual to an emergency department for appropriate sedation. And once you have someone who is appropriately sedated, relocation becomes so much easier. In terms of the natural history, so our thinking has changed over the last 20 years in terms of our approach surgically to anterior shoulder dislocations. So most folks who are young, there is a very high recurrence rate. And what we mean by that is if I have one of my football players who has a first-time shoulder dislocation, it's nearly certain that they're going to have a recurrent shoulder dislocation if we continue the offending activity. That recurrence rate decreases the older someone gets. The hypothesis is that most people who are older are not going to be involved in the higher risk activities, and so consequently they're going to be at lower risk. The other thing that's important to note in this slide is that when we have an individual who's later in life and they suffer shoulder dislocation, there's a high chance that they also have coincidental pathology of the rotator cuff. So one of our assessments is going to be to evaluate the integrity of the rotator cuff after a dislocation. The other thing to note on this slide is that when a shoulder dislocates, you're going to have injuries to the stabilizing structures of the shoulder, including the shoulder capsule and the labrum. And so over the last 10 to 15 years, surgical treatment of a first-time shoulder dislocation has become much more common. In contrast to when I was in my medical training, where we almost never would treat a first-time shoulder dislocation surgically. With improved surgical technique in a young patient, our outcomes are better. And so you will see, if you see a young patient who has had a shoulder dislocation, you should think about a surgical referral to stabilize their shoulder. Next slide. I mentioned some of this already, but obviously when we have a shoulder dislocation, reduction is going to be our thought. Typically, if one is available, you're going to image or complete an X-ray prior to any efforts at a reduction because of the concern for possible coincidental fracture. You're going to try and reduce it and then confirm appropriate placement with a repeat X-ray. You want to assess the neurovascular structures, and primarily that involves the axillary nerve. So the axillary nerve is commonly injured with a shoulder dislocation. So just make sure that you assess that, and in particular, that's checking for sensation on the lateral aspect of the shoulder. Oftentimes, we're going to then immobilize the individual short-term in a sling and have them have close follow-up so that they can advance out of that sling once their shoulder is has less pain, and so we don't suffer adhesive capsulitis as a secondary complication. Conservative care can certainly be done for shoulder dislocation. That primarily involves rotator cuffs and muscle strengthening. In our young athletes, particularly our football players, there is a restraining brace that we will sometimes place them in so that they're at lower risk for dislocations. And then I mentioned previously our concern for rotator cuff pathology, especially in our more senior patients. And so you should have close follow-up to assess the integrity of the rotator cuff. Next slide, please. Okay, next case study. This is a young man that came in my office about 2 months ago. He's a 24-year-old basketball player. He's played at the collegiate level, played a little bit of professional basketball, and he presented a day after he was playing basketball and was trying to overreach with his left hand for a ball, and another player got the ball and it forced his arm. He was trying to bring the arm down and the other player forced it up, and he came in complaining of left shoulder pain, felt a pop, was pretty nervous, pretty anxious about the injury. He described the pain as deep in location. Range of motion initially was very normal, and his pain persisted despite some conservative care. So we got him into conservative care, and he wasn't making a lot of progress initially. So the question here is, what would be on your differential diagnosis?
Generic sprain.
Say that again.
Like a tendonitis.
Good. Yeah. Go ahead and advance to the next slide. So he actually sustained a labral tear. So a labral tear is an injury to the cartilage, which deepens the shoulder socket. And in his case, there are a number of different descriptors anatomically that can be given to labral tears. And in his case, it was something called a slap tear. Now, a slap tear is an acronym which stands for superior labral tear, anterior to posterior. And that's, I don't really want to focus as much on the terminology there, but just to get your understanding that he had torn that cartilaginous rim, and the orthopedist will also grade labral tears by how much disruption of the biceps anchor there is. So the long head of the biceps anatomically advances through the bicipital groove and actually attaches on the superior rim of the glenoid and is intimately involved in the labrum. And so when there is a labral injury, many times it will involve that biceps anchor. Labral tears, we often deal with in the context of our overhead athletes. So these are your baseball pitchers. These are your football players, or anyone who's doing forced rotation of their shoulder. And I mentioned previously that if we have a shoulder dislocation, we essentially almost always have an injury to the labrum when that happens. Next slide. I mentioned the slap tear and how that in the context that I described in my case study, it was acute, but it can also be more of an overuse injury in our overhead athletes. I quoted this next statement because I wanted to be pretty clear on this, because I agree with the statement. The diagnosis generally requires advanced imaging or an MRI, with contrast to assess the superior labrum and the integrity of the biceps tendon. There is some debate in the orthopedic world about which physical exams techniques can help someone identify a labral injury. The short answer is I've not found them to be overly reliable. And I do agree with the author of this study that generally, if we suspect a labral tear, we're going to treat someone conservatively and see how they respond. But generally speaking, we're probably going to want to get an MRI to confirm that that's the diagnosis after a couple of months. I also wanted to quote the author with my last statement is that treatment may be non-operative or operative depending on age, activity levels, and severity of symptoms. So in the athlete that I described, it was pretty interesting. And so he wasn't getting better, and we elected to get the MRI mainly because he was pretty anxious about this shoulder, and I understood it because he had been making a living using that shoulder. So we proceeded with an MRI, which confirmed a labral tear, but it was relatively small on the MRI, which was reassuring. And once we got the MRI, he did improve with conservative care, and so we did not elect to refer him to our orthopedic colleagues for surgical treatment. And so that's an important point here, is that the evidence suggests that many labral tears can be managed conservatively. So just because you have this injury does not necessarily mean surgical treatment is required. Next slide. 75-year-old male presented to my office complaining of right shoulder pain and weakness onset after he was trying to take a big trash bag and toss it into the back of his truck. And he noticed an acute injury then. He's like, wow, man, I had something that really hurt, but he didn't show up in my office for about 2 months. I bring this case study to your attention because I would bet you that any of you providing primary care, you've probably seen this same person walk in your office, or you will. He thought that this pain and weakness would get better with time, but he wasn't getting a lot of improvement, particularly in terms of his weakness, and he noticed most of his discomfort with overhead activities. Anybody want to throw out some ideas in terms of a differential?
What about another tear?
Good, yes. Okay, next slide. So yes, when I examined this individual, he had on examination with our inspection, he had obvious atrophy of the supraspinatus tendon, and with our exam, he had weakness when we tested the supraspinatus tendon using the empty can test, or when he attempted to resist downward pressure on his arm. So we immediately suspected a rotator cuff tear, and it was interesting. You noticed his age; he was 75 years old, and his pain level is actually improving, and so he wasn't real concerned. But I told him, I said, you know, you've got an exam here that is strongly suggestive of a rotator cuff tear, given we've got weakness and atrophy of the supraspinatus muscle. And he was 2 months out when he presented to me. And so the question is, should we refer him for surgical treatment? A couple of principles there is that if you have a rotator cuff tear, it's to our advantage to, if we're going to elect surgical care, to initiate surgical care sooner rather than later, because once the muscle starts to atrophy and the tendon starts to retract from its natural position, it's more difficult and challenging for a surgical repair of that particular tendon. Not that you have to be super quick about getting your patients to an orthopedist, but particularly if you have a younger person, so if you have the 40 or 50-year-old individual, that person, we're going to think about a surgical repair versus my patient. He's 75, and essentially when we talked about it, he's like, look, I don't want surgery for this. And so we elected to manage him non-operatively. He's still my patient. We're 7 years later, and he's doing fine. So that's a rotator cuff tear that we're managing conservatively, and mainly that's because of his age and activity level. I talked about a few of these things that are on the narrative on the left-hand side there. And I mentioned previously rotator cuff tearing with traumatic injuries, specifically shoulder dislocations, but recognize that rotator cuff pathology is a spectrum. And so someone can have fraying of their rotator cuff and ultimately have a tear with a relatively minor injury, like in my example, just throwing a bag of trash in the back of a truck. That's probably a consequence of someone who had a frayed rotator cuff, and then the final acute event ultimately tore the tendon. All right. The other thing you notice in the slide is that, and again, those of you who provide primary care, particularly in rural settings, you're probably going to see many people who have chronic rotator cuff tears that they don't even think about or know about. And so that's always kind of fun. Next slide, please. So when one is assessing a rotator cuff, small tears can and will look like just tendonitis, and recognize that there are different types of rotator cuff tears. And so the smaller, more what are called intersubstance tears will often on examination just look like standard rotator cuff tendonitis. A larger complete tear, what the primary symptom that we're looking at is more loss of function or weakness. There are a number of different ways of assessing for that weakness, but essentially you want to isolate those muscles and test strength. That's really what you want to do. Next slide. I want to talk a little bit about at what point someone should order an MRI. Obviously, first off, we want our imaging study to change our treatment plan. So in the context of the last patient I shared, we did not actually do an MRI in his shoulder because he did not want surgical treatment, and therefore it wouldn't change our management. In contrast to that, if I were meeting with someone who was 45 years old, we would definitely want to proceed with an MRI because that person's got a lot of life ahead of them, higher levels of activity, and would benefit from surgical management. So that's a key distinction whenever we're talking about the role of advanced imaging in musculoskeletal care. Second, if we've got an unclear diagnosis, obviously we had a case presentation to begin with. We talked about the role of advanced imaging in evaluating hip pathology, and certainly advanced imaging would be an option there because we don't yet have a clear diagnosis. Failure to progress, the labral injury I described was an individual who just didn't seem to be progressing with conservative care. And then the other thing that typically I tend to deal with is that our orthopedists will want an MRI essentially on almost everybody that I send to them because it's going to influence their surgical decision-making. And I also wanted to point out, which is very relevant to this audience, that regional considerations can be important. If you live in Alamo, Nevada, you're probably, and you have limited access to an MRI, you might make different treatment decisions than I do living in Reno, Nevada, where I've got an MRI on a couple of street corners nearby. So that matters, and because we live in the real world. And I've practiced medicine in a couple different environments, and so I recognize those things are going to also be part of the medical decision making in terms of obtaining an MRI. Next slide.
Dr. Hall, question on that note, because I mean, and I guess on a patient like that, would a steroid injection or a joint injection be harmful or helpful? Because I know I've thrown that option at my patient. Well, I'm like, well, we can try PT, we can try an injection, and if not, then we can try an MRI. Yeah, what would your feedback be on that?
That's a great question. And I would just let you know, we had our National Sports Medicine Conference for primary care physicians about 2 weeks ago. And I had a lot of discussion about that very question. And there has been, I would say, some increasing attention on biologics like platelet-rich plasma as perhaps a better option. And when I was talking with these docs who are doing these more different injections, let me call them, some of them were of the opinion we should never do a corticosteroid injection. And my comment back to them is, look, we live in Nevada. It's not like this is a big city where we have easy access to those types of things. And so my answer to you would be, I'm fairly comfortable providing corticosteroid injections. So, if you come to my clinic, in a half day, we're going to usually do a couple of injections per a half day. And, but just recognize that corticosteroids can be detrimental if they're used repeatedly to joints and tendons. So we try to avoid repeated injections unless we've got a very arthritic joint. But I would not object to a trial of a corticosteroid injection in most situations where we know we don't have a fracture. And again, in your case where you're in Alamo, I would absolutely use that.
Yeah, because I was just worried about, yeah, agreed. The long-term harm and degenerative changes the steroids can make. Yeah.
Right.
So yeah, thanks for your feedback.
Sure. I'm going to hustle up because we're kind of running out of time, but I wanted to just do one last case study on a 30-year-old female who presented after an acute injury biking when she went over her handlebars. She was localizing pain to the medial aspect of the shoulder, and on inspection, she noted some alteration in the clavicle. Next slide. So clavicle fractures can and do happen. A biking injury is a classic example. Next slide. There's a couple things to understand about clavicle fractures. Obviously, non-displaced clavicle fractures will do well with simple non-operative treatment. My experience is that pain levels tend to come down after a couple weeks, and we try to get the shoulder moving to avoid stiffness. And was some debate about 10, 15 years ago about the right kind of bracing. The simple reality is the standard sling that we use tends to work the best. And again, treatment for non-displaced clavicle fractures is pretty straightforward. If there is substantial displacement, orthopedists are increasingly using surgical treatment to reduce these fractures. And so what was uncommon 40, 50 years ago for a surgeon to repair these, it's become much more common in today's environment for an orthopedist to try and treat a clavicle fracture surgically. Next slide. That's it.
Great. Thank you so much, Dr. Hall. That was a great presentation.
My pleasure.
Yeah. Any questions, comments, anything that you would like to add? Okay. So I guess we can go ahead and wrap up the session. I'm going to send a few links through the chat box. Go, and I'm going to pull up the slide as well. So the first link will take you to our sports medicine webpage where you can see our upcoming dates and times. Our next session is on May 26th at 8 o'clock, and the topic is common bone tumors. And I hope to see you all for that session. This is the link to claim CME or CEU credit. If you're interested, click on that link, complete the evaluation, and put in the code for today, which is 8430. That's the code for today. We are approved for AMA PRA Category 1, nursing, MFT, CPC credits. So if you're interested in claiming any of these credits, click on this link and put in the code 8430. And if you're interested in retrieving Dr. Hall's slides, this is the link. Please click on this link and you'll be able to download his slides. And this is the link to the case review form. I've already shared that with you, Dr. Dalton. And if you have a case that you want to discuss next time, please click on this link, fill out the form, and we will be able to review the case next time. And that's it. I think I'll see you all on the 26th. Until then, take care, guys. Bye-bye.
Thanks. Bye-bye.
Thanks, Dr. Hall. So Dr. Treisman, you asked a question in the chat box. I'm sorry, I didn't see that. So you asked if there's a lack of correlation between tear size and symptoms. We have Dr. Hall and Scott here. Dr. Scott, anything you want to say?
There is a lack of correlation. Depending on the patient, the age, the activity, shockingly can vary. And as Dr. Hall said, sometimes you can find a big tear that is basically asymptomatic. It's a little bit like doing a lumbar MRI on everybody and finding people who have some disc disease with no symptoms. So, you know, a massive tear that's acute, certainly they'll present with the weakness, but sometimes they can have chronic tears that seem pretty large and they've compensated. So the MRI is helpful, but then you have to look at the context of your patient what they need to do, exactly like Dr. Hall said, the 45-year-old in this case may be much different now than his 82-year-old.
Great, thank you so much, Dr. Scott.